Good morning, everyone. We now start our today's session on pediatric anesthesia, and I would like to call upon stage our chairpersons, Dr. A.P. Kataria. He is the professor of the Department of Anesthesia in the Government Medical College of Amritsar and the past president of Punjab State ISA. Next, I would like to call Dr. Baburaj C. Acharya. He is the additional professor, Department of Anesthesiology, consultant in pain and palliative medicine, Government Medical College, Manjari. Next, Dr. Ramesh. He is the superintendent and anesthetist, CHC Armoor, and he was awarded the best doctor from Honorable CM of Telangana. And next, Dr. Jati Shankar Rudra, who is the professor and head, Department of Anesthesiology, Malda Medical College, West Bengal.
A very good morning to all. This session on pediatric anesthesia starts. Let me invite the first speaker, Dr. Ayati Sharma, MD. She's a director, pediatric anesthesia, associate professor of anesthesia. Her topic is coexisting diseases in infants and children, safe navigation to OR. Over to you, ma'am. She said, I think each of our chairpersons will be given the biodata of the next speaker. Probably will be given the biodata.
I hope you all can hear me from here. Really, is it? Okay, thank you. Good morning, and thanks for inviting me to speak on this panel. I would like to congratulate the organizers of the ISICON for all the efforts they've put into making this happen. It's not an easy task. My topic is coexisting diseases in infants and children, safe navigation to the operating room. I understand that this is an extensive topic. So what I'm going to do this morning is to just focus on the issues that are very important to the pediatric anesthesiologist on the daily basis. So as a pediatric anesthesiologist, at least for me, the most important issues are to dealing with the respiratory system. So in the first part of my topic, I'm going to focus on the upper respiratory tract infection and asthma. So let's go ahead. So this is very common in my practice to have a patient with upper respiratory tract infection. And there is no questions that patients coming with URI for the surgery are at high risk of perioperative complications. This is because the viral infection causes morphologic changes in the respiratory system, and that sensitizes the airway to the irritants. So despite the importance of these clinical problems, we are yet to come to a consensus. There seems to be no consensus. I'm not sure about India, but at least in US, there is no consensus as to why cancel the patient, when to cancel the patient, and if you're canceling the patient, when do you reschedule the patient? Do you reschedule after 1 week? Do you reschedule after 1 month? There's really no consensus. The debate goes on. But let's look at the studies, what the studies have to say. So the studies go past almost to 1979, where McGill first time reported. Actually, Dr. McGill is from the hospital where I have myself done the fellowship, which is DC Children's. And he was one of the first persons to realize that children with upper respiratory tract infections have higher incidence of complications when they come for anesthesia. He almost studied 2,000 cases. In 1987, Tate studied almost 3,600 patients, but his study was retrospective. And as you know, the retrospectives don't have really great documentation. Cohen then studied almost 20,000 children and found out that all these studies point that the children with upper respiratory tract infection have higher chances of bronchospasm, laryngospasm, pneumonias, desaturation, and whatnot. So this is what 1991 Cohen reported in his study. We found that children with URI were 2 to 7 times more likely to experience respiratory-related adverse event not only during the anesthesia procedure, but even in the recovery and the post-op phases of the operative experience. So when do I personally cancel the cases? Do I cancel the case when patient just has dry cough? Or what are my criteria? My criteria are usually when they have a severe upper respiratory tract infection, such as the cough with productive sputum, if the patient has fever more than 38, if the patient is lethargic, and obviously if the patient is wheezing and has rhonchi, I personally postpone the case anywhere between 2 to 4 weeks. I usually tell the parents, bring the patient in only when your child is symptom-free. So this is what it says. Children with active and recent URI, less than 4 weeks, has more episodes of breath holding, arterial desaturation, coughing, laryngospasm, bronchospasm. So what are the risk factors? When you have a patient coming in for tonsillectomy or a circumcision, hydrocelectomy, what are the patients that are at high risk? So these are the patients who require endotracheal intubation. If you're just doing a mass case, probably the complication rate is going to be less. Children less than 5 years, obviously, because they have a smaller airway. Children with prematurity, children with reactive airway disease. Also, they have found out